about esophageal tumors, which we'll talk about later on. They talk about rings and webs. And there is a difference between esophageal rings and esophageal webs. Esophageal rings contain basically a muscle in them, whereas a web has no muscle in it. So there is a difference between an esophageal ring and an esophageal web. It can all cause obstruction. They talk about cancers that can be extrinsic to the esophagus as causing obstruction. And again, some of the slides, some of the symptoms that patients are going to present with, if they have obstruction, include dysphagia and the pancreatal dynaphagia as well, which is pain of swallowing. Let's talk about this is an approach to the patient that has dysphagia, and so you might find it helpful in terms of thinking about it. Okay, the patient comes in with difficulty swallowing. How do you approach that patient? Okay, well, the first thing you have to do is ask whether the problem is one of initiating the swallow. Okay, so is it when he goes to swallow, the food goes down the wrong way, or the food comes out his nose, or he has problems initiating the swallow? This is referred to as oropharyngeal dysphagia, okay? And it's usually neuromuscular. It's usually neuromuscular as opposed to gastrointestinal problems, okay? What we're mostly concerned with in this section is esophageal dysphagia. And this is described by the patient of the sensation of the food getting stuck in the esophagus sometime after initiating swallow. Okay? So we're going to focus on, this is oftentimes the problem for the neurologist. This is going to be the gastroenterologist. So once you determine that you're dealing with an instance of esophageal dysphagia, then you have to ask them, okay, is it just solid food or is it solid and liquids? Doesn't matter. Okay? If you're dealing with solids and or liquids, okay, it suggests that you're dealing with a motility disorder, motor disorder. And the next question you want to ask them, if they tell you, okay, solids and liquids, okay, is it sometimes there and sometimes not there? Or is it always there and is it getting worse? Is it progressive? Okay? This is the same slide. It's just a little bit simplified from a different source. Let's keep this one for now. So again, and then what they've done is they flipped it around. So this is where we are. Solid or liquid. It's a motility neuromuscular, just as we saw over here. If it's intermittent, if it's present sometimes and other times not present, you probably also want to ask them, by the way, do you suffer from chest pain sometimes in association? And if the answer is yes, then you might be dealing with diffuse esophageal spasm. Nutcracker esophagus, diffuse esophageal spasm. So this is associated with solid and or liquid dysphagia, which is intermittent and associated with chest pain. All right? If it's neuromuscular, so if they tell you I have trouble swallowing liquid and solid, but it's not intermittent and it's getting worse, okay, then you're dealing with you may be dealing either with something like scleroderma, or otherwise known as progressive systemic sclerosis, or achalasia. And the way that these two things are distinguished, and we'll talk about each of these diseases later on, the way that these two things are distinguished is by asking about symptoms such as chronic heartburn, presence or absence, and asking about the presence of weight loss. Okay? Patients that have scleroderma, so they're going to have infiltration of the entire esophagus with scarring and fibrosis, fibrotic tissue. So you get interference with normal peristalsis, but you also get interference with the normal function of the lower esophageal sphincter. So the lower esophageal sphincter doesn't work the way it's supposed to. It's supposed to basically stay closed all the time until it's time for a bolus of food to pass or a bolus of water to pass. Then it relaxes and then it clamps down again to keep the gastric contents from refluxing up. Well, if you interfere with the lower esophageal sphincter, then the person is going to be prone to the development of reflux and chronic heartburn. So if you have somebody that has solid or liquid food dysphagia that's progressive and it's associated with heartburn, it suggests that you might be dealing with something like scleroderma, or some type of process that's compromising not just the body of the esophagus, but the lower esophageal sphincter. Does everybody see that? If they complain, on the other hand, of the absence of heartburn, they don't complain of it. If they relate the absence of heartburn, okay, then we're more likely to be dealing with something like achalasia. We're going to talk about achalasia, but the thing that you need to know about achalasia right now is it's associated with loss of esophageal peristalsis, but also inability to relax the lower esophageal sphincter. They cannot relax the lower esophageal sphincter. Since they can't relax the lower esophageal sphincter, they're not going to get reflux of gastric contents into the esophagus. So that's why these people do not complain of heartburn. On the other side, you have the patients that complain only of solid food dysphagia. I don't have any trouble swallowing liquids. Liquids go down okay when I eat solid. Now you know you're dealing with a mechanical problem. It means that the lumen is small enough to interfere with the passage of solid food, but not to interfere with the passage of liquids. And again, just as we saw over here with the neuromuscular disorders, the question you want to ask is it intermittent or is it progressive? Okay? If it's intermittent and they have problems with substances like bread, which is dry, and steak, then you may be dealing with something like a lower esophageal ring. Remember, the ring has muscle in it, but the webs do not. If it's progressive, then you're dealing with either something like a peptic stricture or esophageal carcinoma. And again, the way you're going to distinguish these two possibilities, these two diagnoses, is by asking about the presence or absence of chronic heartburn. Because if the patient has chronic heartburn, that's a risk factor for the development of peptic stricture. It's also a risk factor for certain types of esophageal cancer, just to get that aside from that. If they don't have weight loss, again, that's going to argue against esophageal carcinoma. If the person is elderly, older, and has concomitant weight loss, then you need to think about the possibility of esophageal cancer. Yeah. Yes, scleroderma is also known as PSS, progressive systemic sclerosis. And it's sometimes, remember the CREST syndrome? We talked about the CREST syndrome, calcinosis, Raynaud's, esophageal dysmotility, sclerodactyly, and telangiectasias. So esophageal dysmotility is one of the characteristics of the disease. So again, this is, if you have a patient that complains of difficulty swallowing, you should now know exactly, or these are the questions I have to ask. I need to sort out whether it's oropharyngeal or esophageal. If it's esophageal, I need to sort out whether it's neuromuscular or mechanical. And then whichever one of those it is, I have to decide whether it's progressive or intermittent. And you can work your way down to a particular, to a suspected diagnosis based on the history that you obtained from the patient. Okay? Any questions about any of this? Again, it's the same, essentially the same slide as the one like that. All right. All right, so let's talk about, let's see. They talk about, well, at the bottom of page 72, they talk about some diseases that are associated with failure to contract. And they talk about, they say that esophageal dilatation can occur in scleroderma. Here, scleroderma. We mentioned the chronic heartburn in scleroderma. The muscle of the lower esophageal sphincter is replaced by fibrous tissue, and so that is why they get dysfunction of the lower esophageal sphincter, and that's why they predispose to the development of chronic heartburn. They also point out that you can see esophageal dilatation and failure to contract in Chagas disease. Chagas disease is American trypanosomiasis. You see destruction of the myocytes and the denervation. I'm not going to talk too much about Chagas disease. I will just say a couple of things about it. There's a couple of different phases. Okay, there's an acute phase that can be asymptomatic, and then there's the chronic phase, which is associated with a dilated cardiomyopathy. I can't remember when we talked about dilated cardiomyopathy if we talked about Chagas disease. Did we? What's that? Okay, we did not. So if you go back to page 8, you can add Chagas disease to the differential diagnosis of cardiac dilatation. All right, it's associated with dilated cardiomyopathy and megaesophagus. Esophageal dilatation. Okay, so at the top of page 73, they talk about failure to relax. So again, we're talking about now disorders of the muscle of the esophagus. We talked about failure to contract and esophageal dysmotility. We talked about scleroderma. We talked about Chagas disease. We're also going to talk about achalasia in a little while. Okay, but now we're talking about failure to relax. And the disease that they mention in that regard is diffuse esophageal spasm, which, remember, we said is associated with neuromuscular dysphagia that is of the intermittent type. Okay, and diffuse esophageal spasm causes intermittent neuromuscular dysphagia, and you see that what you can see on the imaging is the so-called nutcracker esophagus. So non-cardiogenic chest pain shows multiple areas of spasm throughout the length of the esophagus. Okay, this is more than just peristalsis, it's spasm. These episodes, they can be triggered by very hot or very cold foods. So they might notice that they get chest pain when they eat something that's at an extreme of temperature. And the pain that they get mimics the pain of angina. Okay, so we talked about disorders associated with failure of the esophagus to contract, disorders associated with failure of the esophagus or parts of the esophagus to relax, and then you have achalasia, which is the paradigmatic example of the failure to contract and relax. So, as the book points out, patients that have achalasia, the lower esophageal sphincter is constricted, it remains constricted, it does not relax, and the lower two-thirds of the portion of the esophagus lose the ability to engage in peristalsis. And so what you get is you get dilatation of the esophagus. Okay, here, you see how dilated the esophagus is. Okay, and then you get narrowing here at the lower esophageal sphincter. So this is the so-called Bird's Beak appearance. kind of looks like a bird's head here. There's the beak. So there's the bird beak appearance of achalasia. Remember we said that achalasia is associated with neuromuscular dysphagia that is of the progressive type, okay, and it is unassociated with any complaint of chronic heartburn. You see why that is, because look at the reflux, okay. Now they can regurgitate. Obviously, this is an area where they're going to pool secretions, pool food. They can regurgitate stuff, but it's going to be bland. It's not going to contain gastric acid. And the pathophysiology that underlies achalasia is that you get destruction of the postganglionic parasympathetic neurons. Again, it causes progressive neuromuscular dysphagia. So the differential diagnosis is going to include scleroderma, again, but without the heart rate. Okay. The next topic that they talk about are diverticula of the esophagus, and they talk about a couple of different types. Diverticula, as they define them in the book, outpouches of the esophagus. They talk about a couple of different types. The first one that they talk about is a pulsion diverticula, and pulsion diverticula do not contain any muscle in the wall of the diverticulum. I guess the way to think about pulsion diverticula would be they are analogous to the diverticulum that you develop in the colon with a diet that is poor in fiber. It's related to intraluminal pressure. You get outpouching, but those outpouchings are through the muscle layer. They don't contain, through defects in the muscle layer, they don't contain muscle in the tip, in the wall of the tip. Traction diverticula, which you can see if you get fibrosis related to tuberculosis, for example, that actually pulls on the esophagus and causes the diverticula. Traction diverticula do contain muscle in the wall of the diverticula. Zenker's diverticulum, which is depicted in the slide over here, they point out that it's usually located behind the upper esophageal sphincter. It's an outpouching of the lumen, and food and drink can get stuck there, and patients then can regurgitate the undigested food later on. Okay, so you remember that the GI tract has 3 layers, right? So yes, the entire layer has muscle. The entire esophagus has muscle. Remember that there's there's 2 different muscle layers, right? There's one that's longitudinal, and then there's one that's this way, horizontal or circumferential. And then you haven't talked about it yet. The stomach has a 3rd layer, right? Okay. But remember that the muscle is not one sheet. There are fibers, right? That way, and then this way. And so, right, let's say you could go between, you find defects between adjacent muscle layers in both layers. You get adjacent muscle fibers in both layers. And so if the pressure gets big enough in the lumen, the pressure gets high enough, then what you do is you basically force the mucosa through that defect in the muscle. And you have, if you're looking at it from the side, here's the serosa, which is the outside layer. Okay, here's the esophagus. Okay, and here is here's the mucosa in red. Okay, what happens is you're basically just pushing it out. You're going through the defect in the muscle. Okay, so there's no muscle in that diverticulum. What you'll find in that diverticulum is you'll find mucosa and serosa, and that's it. Okay? Any questions about anything that we talked about so far? Okay, so there's the Zenker's diverticulum. Obviously, it's a place where foods collect and then come back later on. The pathophysiology of the Zenker's diverticulum is thought to involve a discoordination of the swallowing mechanism with the proximal pressure, which gives rise to the diverticulum. And these patients can complain of dysphagia, regurgitation, and they're prone to the development of aspiration as well. So the content here can reflux up, regurgitate up, and then they're prone to aspirating that into their airway. Questions about that? Okay. So, okay, let's talk about reflux, gastroesophageal reflux disease. So this is a common problem. You will see this quite a bit, gastroesophageal reflux disease, and it can present in a number of different ways. They point out that it is the most common disorder of the esophagus. It's the term that's used to refer to the reflux of acid back up through the lower esophageal sphincter into the distal esophagus, and that can produce esophagitis. As we'll talk about later on, it predisposes patients to the development of certain types of esophageal cancer. So it is not a completely benign entity. And obviously they could develop bleeding associated with esophagitis, so it's not benign from that standpoint either. It can also be associated with nocturnal cough. Sometimes gastroesophageal reflux disease presents with nocturnal cough, so you need to be aware that it sometimes has non-GI manifestations. So there are three dominant mechanisms that underlie the development of gastroesophageal reflux disease. Okay, so here's the lower esophageal sphincter over here. Okay, and the question is, how does the proton get from there to there if the lower esophageal sphincter is doing its job? There are three different ways it can happen. First of all, you can have something called transient lower esophageal sphincter relaxation. Transient lower esophageal sphincter relaxation, which is exactly what it says it is. That from time to time, for brief periods of time, the lower esophageal sphincter loses tone and allows the reflux of gastric contents up into the distal esophagus. It relaxes and then it's constricted at a time when it shouldn't be relaxed. It relaxes unassociated with swallowing, unassociated with the passage of food. So transient lower esophageal sphincter relaxation is one mechanism. The second mechanism is that you might just have a hypotensive lower esophageal sphincter. Okay, so if you were able to measure with some type of manometer or something the pressure inside that lower esophageal sphincter, you have a lax sphincter for some reason. The sphincter is not sufficiently tight. And so if the pressure in the stomach or in the abdomen rises above the pressure, let's say, on the lower esophageal sphincter, you're going to overcome its resistance and you're going to reflux the gastric contents back up into the esophagus. Okay? That's number two. The third possibility is that you can have some anatomic disruption of the gastroesophageal junction. And an example of that would be like a hiatus hernia. You have an anatomic disruption of the gastroesophageal junction. That would be the third possible mechanism. They point out that some of the symptoms patients can have associated with GERD include heartburn. Surprisingly, sometimes there's a sour taste in the mouth, or patient appreciates an acid taste in the mouth. They can have chest pain, and so in certain instances you may have to distinguish it from cardiac disease, depending on other things that are going on. It may be positional. And as I alluded to before, it's associated with the development of chronic changes in the esophageal mucosa, the so-called Barrett's esophagus, where the distal mucosa here undergoes metaplasia, protects itself from the acid. And so the mucosa, which is normally squamous over the squamous cell, it begins to look like a columnar mucosa, which you would have, let's say, would be normal over here, but not up there. So as you get that metaplasia, that's referred to as Barrett's esophagus. It's actually visible. You can see it grossly at the time of endoscopy. You can see where the squamous mucosa becomes columnar mucosa, so it's actually grossly visible at endoscopy. And those people that are at higher risk for the development of adenocarcinoma of the esophagus. Okay, so here's the lower esophageal sphincter. And this is a summary of some of the things that can affect lower esophageal sphincter tone and gastroduodenal motility. So, so things that can increase lower esophageal sphincter tone. Okay, that's a good thing for people that have reflux. Metoclopramide. This drug was very effective, but it's not on the market anymore. It's a surprise. It's off the market. Things that decrease lower esophageal sphincter tone. These are things you need to be aware of, because if you put the patients on this, they might develop gastroesophageal reflux disease and signs and symptoms of that. So nitroglycerin can do that. So if somebody has a positive response to nitroglycerin, usually we say, okay, that's suggested that they have cardiac disease. But just be aware of the fact that not necessarily, okay? It affects the muscle in the esophagus as well. And so if somebody, let's say, has nutcracker esophagus and you give them a glass of nitroglycerin, well, efficiency gets better, that would be consistent with that too. Calcium channel block. Okay, these things can cause symptoms of reflux disease. Okay. Oh, these are important. Chocolate, coffee, and peppermint. Right? What do you notice about that? This is what they give you when you go to a restaurant, right? Would you like some coffee? All right? They give you, would you like some of this chocolate torte? Okay? And then when you're walking out the restaurant, the peppermint. Why do they do that? They do it because it makes it easier to burp. Okay? It opens the lower esophageal sphincter. Okay? And all of that stuff that you crammed in there, now it has an outlet. Okay? So just be aware of that. All of these things, there is a reason why we eat them after dinner, but they also decrease lower esophageal sphincter. Okay? All right. Any questions about that? Okay, so they talked about, so far we've talked about gastroesophageal reflux disease. We said that one of the things that it can do is cause esophagitis, cause symptoms of esophagitis. But there are other things that can cause inflammation of the esophagus as well, and that's what the next paragraph is designed to talk about. And so they point out, for example, that esophageal inflammation or esophagitis can be caused by medication. And they give you the example that they give you is chemotherapy. Certainly chemotherapy can do that because it wipes out the rapidly dividing cells that line the mucosa. But what you need to be aware of is that just any kind of pill that you give somebody, if they don't drink it with enough water, and it gets stuck, some people, it's like a badge of honor or something that they can dry swallow pills. Well, they get stuck. They really do get stuck on the way down. They may not even know it, but they get stuck. And what happens is that when the capsule melts, or not a capsule, but the pill, a lot of times the drug itself is corrosive to the esophagus. So, for example, potassium is awful for the esophagus if it gets stuck in the esophagus. Of course, the stuff that we use for osteopenia, those pills, they're really bad for the esophagus. So you have to make sure that people take their medications the right way. So this is a medication review also. It's very discreet where the pill got stuck. It does that problem. Yeah. I think the applesauce is mostly for swallowing purposes, but like this is the one I'm thinking about, the one that they you can't take it with anything except water. You can't lie down for a half hour. You can't eat anything else. What's the medication I'm thinking of? Huh? Yeah, for osteoporosis. Yeah, it's Fosamax. I remember I had a patient that I had osteoporosis, and I put her on Fosamax, and she got the worst case of esophagitis. So I was going to have to put her in the hospital. Really awful. So anyway, and that was even after warning her to take it. You got to take it this way, and she got it anyway. So yeah. So okay. So medications can do it. Radiation-induced esophagitis, infectious esophagitis. So, for example, patients that have HIV can develop candida esophagitis, which is the most common type of esophagitis that patients with HIV develop. There's a patient with candida esophagitis. Physical at the time of endoscopy, so they can develop dysphagia associated with that, or dimophagia rather. And they can develop herpes simplex esophagitis as well. This is a barium swallow in a patient with herpes simplex esophagitis. And they point out that other things can do it as well, including cytomegalovirus esophagitis, it's an HIV type of esophagitis. Because Candida is so common, because it's so commonly the cause of esophagitis in patients with HIV. Sometimes if the HIV patient comes in with odynophagia, they will try an empiric course of diflucan prior to proceeding to endoscopy. And if the empiric course of diflucan, again, targeted at the Candida doesn't work, then they'll proceed to endoscopy and they'll make a diagnosis, a definitive diagnosis. Questions about anything so far? All right, so there's esophageal cancer is the next topic, and it's discussed briefly, but it is an important topic in spite of the brevity with which it's dealt. Okay, so let's see. They point out that there's an abrupt transition between the squamous line mucosa and the bronchial lines of mucosa of the stomach. Okay, you can see that transition over here. Right? See it over here as well. In B, this is a patient that has Barrett's esophagus. And so the squamous epithelium of the esophagus is being replaced by columnar epithelium to protect it from the refluxing acid. So there are two different types of esophageal cancer. There's adenocarcinoma of the esophagus and squamous cell carcinoma of the esophagus. Adenocarcinoma of the esophagus is the type of carcinoma that patients get if they have gastroesophageal reflux disease and Barrett's esophagus. They are predisposed to the development of adenocarcinoma of the esophagus. And squamous cell carcinoma is the type of cancer of the esophagus that people get if they drink and they smoke. Smokers and drinkers are predisposed to the development of squamous cell carcinoma. I had somebody that was an older couple, but they were friends, and so the husband developed esophageal cancer, and his wife said, I told you shouldn't have smoked, I told you shouldn't have drank, I told you shouldn't have smoked, I told you shouldn't have drank. And it turned out that he had adenocarcinoma of the esophagus. So I couldn't help myself. I had to tell her that, he would have gotten this anyway. It had nothing to do with smoking or drinking. So, and sometimes that's a good thing to do. Sometimes you can relieve the patient's guilt by telling them, hey, this had nothing to do with anything that you, this had nothing to do with anything that you did to yourself. In fact, I think that might be one of the reasons that people come to us. I think that sometimes they come to us for absolution, especially for medical operations. All right. let's finish up the esophageal material and then we'll take a break. Esophageal varices refer to dilation or dilatation of the veins, plexus of veins at the gastroesophageal junction. And as the book makes clear, you normally see this. Gastric varices, gastroesophageal varices are normally seen in patients that are normal, but they are seen in patients that have, for example, portal hypertension, cirrhosis, ascites. Okay, so it's associated with the development of liver disease and portal hypertension. And so you get dilatation of these veins, and they are prone to bleeding, prone to the development of bleeding. And when they bleed, the patient can bleed profusely. It's a GI bleed. They're bleeding into the GI tract. They can present with hematemesis, or melena, or hematochezia, which is bright red blood to the rectum. I should make clear that these things do not cause, although they can be quite big, they don't obstruct the lumen. They don't cause dysphagia. Okay? Yeah, hold on. What were you going to say? No. We'll talk about that in a second. So here's the lower esophageal space, so that's the area of interest. And you can see the esophageal varices running longitudinally, okay? And then just to give you a this is a endoscopic view. And you can see the varus over here. You can see the varus. So this is the varus over here. This is the vein. And that's if they don't get, because it's compressible, they don't have this odynophagia. The reason that they don't get dark blood is because in order to get dark blood, are you saying because it's venous blood? But it's not dark blood because it's not exposed to gastric acid, you know, or if it goes down into the stomach and then it comes up right away, it doesn't have any time for the acid to work its magic to turn it dark. So it's usually bright red blood that's coming up. And sometimes the blood that's going through the stomach, if it has time to be worked on by the gastric acid and the bacteria, it's going to come out the other end as melena. But sometimes the bleeding is so profuse, so rapid, that it comes out bright red at the other end. So they can have melena, they can have hematochezia, hematemesis. You can have coffee grounds, which is referred to as coffee grounds emesis, if the blood has been acted on by the gastric acid and they throw up stuff that looks like coffee grounds. But to the extent that it's a brisk bleed and it's not spending any time to speak of in the stomach, then they're just going to vomit bright blood. Okay, and then what else did I want to tell you about this? Okay, so this is just so that you have some type of, we'll do these slides and then we'll stop. Some understanding of portal hemodynamics. Actually, I think we'll probably come back to this stuff when we talk about the liver. So we'll come back to this. Let's go ahead and stop now. We'll come back at 11.